I was told to give a talk in the neurology grand rounds, and I'm thinking what would be most appropriate for neurologists pertaining to the pituitary problems that I see day to day in my practice. So I thought maybe it would be appropriate to talk about pituitary patients or potential pituitary patients that neurologists might see that might turn out to end up having pituitary problems. So that's why I'm titled my talk as Approach to Pituitary Patients for the Neurologist, although this is not exhaustive, but I'll try my best to cover some topics of some of the patients that you might see. So obviously the first symptomatology that patients would present to a neurologist would be headaches, and it's a pretty common symptom seen in your practice, I'm sure, and mine too, which is why our clinics are actually next door to one another, and we can sort of hand patients off to each other. And the headaches are pretty common, as you can see here, and they can be classified into different types here. And the prevalence of different types of headaches in different age categories are not surprising. And you can see here that headaches, particularly even in children and adolescents, are pretty high up there, up to almost 50% of the population. Then you have migraines, tension-type headaches, and chronic daily headaches that follow along. But what I want to focus on is headaches that are associated, or maybe that the patients present that may have underlying pituitary disorders, and some of the symptoms that may actually make you think that they may have underlying pituitary diseases. And obviously, for headaches associated with pituitary disorders, is really dependent on some of the headache characteristics can actually give you some clues. Presence or absence of symptoms attributable to pituitary diseases, because if it produces excessive hormones, if the pituitary has a tumor that produces excessive hormones, you can actually have systemic diseases that may actually give you a clue, and also the imaging characteristics of the lesion. The typical characteristics could be one-sided or bitemporal, migraine-like periorbital stabbing, throbbing, or sometimes even cluster headaches. However, the mechanism of headaches is actually not well understood. And these are some of the hypothesized factors that may contribute to why patients with pituitary diseases present initially with headaches. You can have the tumor eroding laterally into the cavernous sinus, and sometimes a common tumor would be cavernous sinus meningiomas. You can have compression of vessels and pain-sensitive structures. You can have stretching of the dural lining of the cella. You can also have increased intracellular pressure. Cystic changes, specifically patients with Rathke cysts, can have changes in pressures which can contribute to headaches. Hormonal hypersecretions, specifically acromegaly, can cause bad headaches. Sometimes overdosing of medications such as growth hormone or glucocorticoids can also do that. Inflammatory processes such as hypophysitis, and changes in blood supply, specifically patients who have had, for example, traumatic brain injury, which can affect the blood supply to the pituitary. And I don't need to tell you the anatomy, and the reason I put up this slide is just to show you that because the pituitary is located to very near all these structures next to the cavernous sinus, which contains all the important optic nerves and also the carotid arteries. So any changes in pressure or any changes in blood supply can actually cause headaches. And you can see also there's dural lining in the pituitary gland there that can also be stretched because of the increase in tumor size. That can also facilitate headaches. Not forgetting the fact that if the tumor enlarges and compresses on the optic chiasm, giving you double vision, that can also give you headaches too. Important to remember is the fact that there are caveats to headaches in a patient with pituitary problems. Like I alluded to earlier, when you have excessive glucocorticoid administration, for example, that can promote hypertension, patients with acromegaly or patients who are excessive growth hormone administration causing fluid retention that rises the cerebral pressures that can cause headaches too. Primary hypothyroidism, very common. I saw a patient yesterday with a TSH of about 50 that because of the TSH is so high, the pituitary just enlarges and that can cause headaches because of the compensatory mechanism. Patients with pituitary tumors due to prolactin secreting tumors, inflammation, and also patients not forgetting traumatic brain injury. There's also a new, recently also subarachnoid hemorrhages also can affect the pituitary, specifically if you have lesions in the circle of Willis that can affect the pituitary function. That can also present with headaches as well that are not mentioned here. We know pituitary tumors are actually common. About 10 to 15% of patients, even up to 20% in the general population have tumors. If you scan them, you'll find that there are tumors there, but they're most usually benign and they are non-functional. But the problem is headaches are also common in the general population, okay? And so if you combine headaches with a pituitary lesion, you'll find that it can go up to about 33 to 72% of patients who present with headaches with a pituitary lesion. And this is just a slide to illustrate the point of the different types of pituitary lesions that can present with headaches. And you can see here, apoplexy is generally the most common lesion, affecting up to 85 to 85% of patients. Also, Rathke's cleft cyst, because of the changes in the cyst, in the size of the cyst, hypophysitis, which is an inflammation in the pituitary, and also craniopharyngiomas. You have the endocrine adenomas, which are non-functional. They are not that common, perhaps about 25%. And the functioning tumors are generally, perhaps maybe like acromegaly, most commonly about 30, almost up to 30% that can contribute to headaches that may present as headaches initially. So if you look at this table here, you'll see that the factors that actually can help you predict the types of headaches in patients presenting with pituitary tumors. So they generally typically are presenting with, they're younger, they tend to be females, and as I showed you earlier, Rathke's cleft cyst and apoplexy are the two major pituitary lesions that can present with headaches. And then also, if you've had a patient who's undergone surgery, typically if they present with short duration of headaches or gross total resection of the tumor, they generally have improvement much faster than the other factors as listed here. Okay. So important when you see a patient with the pituitary tumors or pituitary lesions, important is not to miss adrenal insufficiency and not to miss a patient having underlying prolactinomas, because the treatment for prolactinomas, at least initially, is not surgery, but is medical treatment. If the patient presents with acromegaly, obviously you will see some signs and symptoms, specifically the classic textbook symptoms of the large jaw, the prognathism, the frontal bossing and all that. So that's easy, and checking an oral glucose tolerance test in IGF-1 is mandatory. If the patient has Cushing's, those are the tests that you would do to assess for Cushing's. And for patients who present with non-functioning tumors following headaches, these are all the tests that we would generally typically do, and those make up predominantly the most common or the larger proportion of patients that present with pituitary tumors. But if all else fails, just send them to me then. Okay, so management, generally we evaluate the pituitary function. Typically you can be divided into the hyperfunctioning tumor, which you have the Cushing's, acromegaly, and prolactinomas, and then you have the non-functioning tumors. Okay, and generally for prolactinomas, dopamine agonist is usually the first line treatment before surgery is considered. You have patients with Cushing's and acromegaly where surgery is generally the first line treatment followed by medical therapy. And also patients who have these lesions generally will probably require other hormonal replacement therapies as well. But most commonly, we'll see patients with non-functioning tumors or presenting with cysts. And you can either, depending on the nature of the tumor and also the size of the tumor, sometimes we may consider conservative as opposed to surgery. If the tumor is large and is causing compression to the surrounding structures, potentially surgery or radiotherapy is considered. Okay. So this is a study that I put up here to illustrate the point of a patient who has non-functioning adenomas, and not all patients with non-functioning adenomas need surgery. So what they did was they looked at patients with macros versus micros, and solid versus cystic. And what you can see here is no surprises there, that if you have a macro, the natural history is that it's obviously going to enlarge more likely than a micro. And if the tumor is solid as opposed to cystic, the chances of it enlarging is greater. In terms of endocrine dysfunction, again, if you have a macro, you are more likely to have hypopituitarism as opposed to micro. Again, no surprises there. Everything else, like apoplexies or worsening visual fields, do not tend to affect the natural history of these tumors. So the algorithm for treating non-functioning macroadenomas generally is dependent on two things. Number one is if the patient presents with a visual field defect, and if so, if the vision is compromised, then definitely surgery is indicated. And usually what happens is after surgery, we'll monitor these patients with an MRI, or and if they need radiotherapy, if there's still remnant that is growing, that would be considered. If the vision is not affected and if the patient does not complain of any other symptoms, typically we could consider not even considering surgery, but just keeping an eye on these patients. And obviously considering surgery if these symptoms worsen. Rarely in individual cases, headaches can also be considered a cause or a reason for considering surgery in these patients. Now, we also tell the patients, if you have a macro, the likelihood of developing an apoplexy is obviously higher than a micro, and that potentially can be a problem, especially if they present with bad headaches or visual disturbance from an apoplexy. So that's certainly something that we generally tell our patients as well, if they have macroadenomas, which may require surgery eventually. So other common neurological symptoms, apart from visual disturbances, are cranial nerve palsies, particularly in cavernous sinus meningiomas, carpal tunnel syndrome, particularly in patients with acromegaly and Cushing's, and peripheral neuropathy, again from the ensuing diabetes that may be a factor in patients with acromegaly and Cushing's as well. The other thing I wanted to bring up for patients presenting to a neurologist is the fact that these patients, that you may see many patients on anti-epileptic medications. And it's important to be aware that patients who are on anti-epileptic drugs, that potentially there can be interactions. Particularly, some drugs can actually enhance the hepatic expression of the CYP3A4 activity, increasing either increasing or decreasing the efficacy of the drug and also the hormones. They can also increase sex hormone binding globulin, specifically if in patients who are on hormone replacement therapies that might actually affect their hormone replacements. They can also decrease plasma drug levels. It can also have an effect on sex hormones and their metabolites. And also, for example, testosterone can also have an effect on neuronal excitability as well. Some medications, some antiepileptics can also affect the sensitivity of renal tubules, affecting the effects of desmopressin in a patient with diabetes insipidus. So that can also have a problem and can also enhance the thyroid hormone metabolism in patients on thyroid hormone replacement. So again, just a slide here to illustrate the potential interactions, and you can see here that especially the typical drugs that can affect the CYP3A4 inducers, phenobarbital, phenytoin, carbamazepine, oxcarbazepine. So those types of medications can actually interact with patients if they are on hormone replacement therapy as well. And one of the things that it can also affect is inducing SHBG, which can then reduce, particularly in women on oral contraceptives, they can actually reduce the efficacy of the pill as well. So that's actually very important, especially when you're counseling these patients. So key points, estrogens and thyroid replacement can actually lower seizure threshold and potentially can decrease plasma levels of anti-epileptic drugs. So it's crucial that you're aware of it, especially if they're on these medications. Some antipsychotics and antidepressants can also cause hyperprolactinemia, which can affect their menstrual cycles and can cause galactorrhea as well. Testosterone can exert anti-seizure effects. Chronic use of enzyme-inducing antiepileptics can also increase the CYP3A4, leading to enhanced clearance of dexamethasone, which we use especially in neurosurgery, where we use a lot of dexamethasone post-operatively as well. Induction of this enzyme can accelerate the metabolism of levothyroxine, so they may feel that they're under-replaced in some patients. And particularly in carbamazepine or oxcarbazepine, these medications can actually affect the renal tubules and potentially cause SIADH, or the effects of SIADH from concomitant use of desmopressin. So these patients can present with water intoxication and hyponatremia as well. So this is not an exhaustive list of medications I alluded to earlier that can actually affect the prolactin levels of patients that some of you may consider using, like antidepressant agents, antipsychotics, especially risperidone. So I get referrals sometimes of patients coming in with hyperprolactinemia on risperidone. And the treatment for these patients is actually quite challenging because you can't really stop these medications, and yet they're having high prolactin, galactorrhea, and they're trying to get pregnant. And so that's where the problem arises, where you may need to have a conversation with the psychiatrist to see if they are able to change that or change it to an alternative antipsychotic, because that can actually potentially cause hyperprolactinemia as well. So I'm just going to go through some case discussions here, switch gears a little bit, to highlight some of the cases that I've seen recently that may actually impact your management as well. So this is a 56-year-old male with MS, and MS patients tend to present with headaches as well. So MRI was ordered as part of a treatment protocol, and that was when an incidental microadenoma was seen on the MRI. He was also complaining of new onset of diabetes and pains in his joints. And because of all the findings on the MRI, he was referred, and the positive finding was an IGF-1 that was elevated. And this is the MRI, and you can see on the left side is where the microadenoma is. So clearly this guy had very subtle symptoms of acromegaly, and we went on to do an oral glucose tolerance test. So the idea of doing an oral glucose tolerance test is to confirm biochemically confirm the presence of acromegaly. So what you do is you give the patients a drink of glucose, and then you measure their glucose levels every 30 minutes. And what you can see here is on the you measure the growth hormone levels as well simultaneously, and if growth hormone levels do not suppress below 1 nanogram per mil, that is highly suggestive of acromegaly, because what happens is when glucose levels rise, it suppresses growth hormone in a normal person. So in a patient with acromegaly, growth hormone levels remain flat, as in this case. So this guy had really mild acromegaly, which was contributing to his headaches, and because he was having MS, an MRI was performed, and that's how he was discovered. Stage 2 is a 28-year-old male with a non-functioning macroadenoma that was known, and as I said earlier, macroadenomas generally, if they are asymptomatic, we generally don't consider surgery unless they're affecting the vision or patient is complaining of headaches. And in this case, this patient was well, and then suddenly short history of sudden frontal headaches. And when it was referred, almost all of his hormones were really low, including his IGF-1, suggesting that he also had growth hormone deficiency as well. And if you can see here, the tumor here, there's also seen that is also pushing up onto the chiasm, and what's happening here is also there's blood-filled necrosis within the pituitary, suggesting that this patient had an apoplexy, which can present sometimes subacutely and sometimes acutely. So just a little bit about apoplexy. Apoplexy is actually relatively rare. And the most common symptom that these patients present are headaches, or bad headaches, I should say, associated with vomiting, ocular palsies, and impaired visual function. The MRIs, generally you can see a hemorrhage or infarction of the tumor, and the diagnosis is generally delayed because of the fact that if the headaches are not bad, patients don't end up being seen. Hypopituitarism is frequent, and typically these patients require prompt treatment with glucocorticoids. The question of whether we should consider surgery, immediate surgery, versus waiting and watching and waiting is still debatable. So currently we are doing a study in several centers in the US, looking to see if conservative, meaning giving these patients glucocorticoids, versus immediate surgery, to see which whether which part the treatment which is more effective is being done at the moment. So we are looking at studying this, but at the moment the issue of conservative treatment versus surgical treatment is still not clear. Although if the patient has severe visual compromise, I would think surgery is definitely indicated immediately.
Yeah, but what dose of glucocorticoid?
Yeah, dexamethasone doses. So 2 to 4 milligrams BID to TID. Yeah. The idea is to reduce the inflammation and the effects on the pressure on the optic chiasm. Yeah. Finally, and then I have a patient of a Hispanic female with acromegaly, and has had numerous surgeries, and including cranial radiation. Headaches are still present. Probably she also has underlying carpal tunnel syndrome as well, with tingling and numbness and bad diabetes. And this is a tumor that's actually going upwards and going sideways, so a pretty nasty looking tumor. And the headaches actually continue to worsen even after surgery, despite biochemical improvement. And so we ended up treating her with lanreotide, which is somatostatin analog, and over time, her headaches gradually improved. So a little bit about acromegaly headaches. So acromegaly headaches are generally very difficult to treat. We still don't know the exact mechanism of these headaches, why patients with acromegaly tend to have headaches despite biochemical improvement. Generally, short-acting octreotide is actually quite effective, and we have patients where we use the octreotide specifically for the headaches, not for control of acromegaly, because they actually work quite well in majority of patients. Long-acting somatostatin analogs can actually also improve these headaches as well, but because they are long-acting, it typically takes a while for it to kick in. So in general, about after the 4th to the 6th injection, before these headaches can actually improve. It's thought that the somatostatin analogs actually and its binding to SST receptors actually has an effect in suppressing the pain pathway in these patients. And that's why in patients with prolactinomas, non-functioning adenomas, and TSH secreting tumors with headaches, sometimes the SSAs have been used quite effectively as well. Again, mechanism is still unclear. Problem is that when you use SSAs in these patients, there is a chance that they may develop dependency syndrome or rebound headaches because of the effects it has on the receptors. So when you stop it, you can actually have rebound headaches, just like the analgesias that you use for headaches as well. And the idea is that because of the fact that there are SST2 receptors in the periaqueductal gray matter hypothalamus and trigeminal nucleus, sometimes SSAs can also be used in patients with cluster headaches and migraines as well. Again, there's not a lot of data out there on this, but certainly anecdotally it's been used in some patients. And this is a nice paper that was published giving a nice review on the association of tumors and treatment of pituitary tumors and headaches. And finally, I have a last case. This is a young girl with 8 weeks postpartum. Again, bad headaches and visual disturbance that may present to a neurologist. Also had some nausea and lightheadedness and very low IGF-1. All the other labs confirmed that she also had other pituitary hormone deficiencies as well. And the interesting thing is, if you look at the MRI, you'll see that the pituitary is bulky. In fact, the stalk is actually quite bulky and actually is moving. It's actually pressing upwards onto the optic chiasm. And the key sign is that you have a dural tail there, which I'm told is a radiological image of a patient with autoimmune hypophysitis. Essentially, what it means is that this whole pituitary is inflamed and typically tends to occur after pregnancies, where again it's an autoimmune disease where patients can actually present generally with bad headaches and visual disturbance because of the enlargement of the pituitary from the inflammation. So again, for these patients, management of these patients is actually challenging because you can either consider performing a biopsy, or surgery, but we generally don't want to do that in a young female. Doing a biopsy is almost like doing surgery. But nevertheless, this patient underwent a biopsy and had inflammation with lymphoplasmacytic infiltration. The other option is to empirically treat these patients with high doses of steroids. I don't usually like to do that because when you put them on high doses of steroids, then it becomes a problem trying to wean them off over time. Surgery obviously relieved the headaches, but in a young woman like that, she's panhypopit and amenorrheic and not good in terms of future fertility prospects. So generally, this is a tough one, but her tumor was large enough and threatening of vision that required surgery in this case. And this is the biopsy showing extensive infiltration of inflammatory cells in this patient. And the last thing I wanted to highlight is recently, not so long ago, there was a paper that was published in Neurology about the use of growth hormone in childhood short stature. And I think this paper kind of created some controversy. It came up from France, so no surprise there. But essentially what they found was that childhood short stature patients who ended up becoming, or they thought were growth hormone deficient when they were adults, were treated with growth hormone, and they looked at the registries of these patients, and they found that there was an increased risk of strokes in these patients, which is bizarre. And so there were several questions that came my way about whether growth hormone treatment in patients can actually cause strokes or not. It's still very highly controversial, but I just wanted to highlight this because it's still out there, and I'm still getting questions on this. But if you look closely at the study, you'll see that there are several limitations of the study and how it was performed. Certainly, ascertainment bias was there, and there were and two control groups were actually from a general population. So these were actually retrospective data, and generally I would say that growth hormone is still pretty safe in patients, and that stroke is not so much, and I have not seen any strokes in my patients to change my practice in putting these patients if they need growth hormone. So just out there just to let you guys know, okay? So this is my last slide. Am I assuming I'm a hypochondriac, that condition be brought on by a brain tumor? Thank you.